presence, which has continuously reminded us of your faithfulness and your guidance, even with us in our various consulting rooms. Today, oh God, we humbly ask you that you grant our speakers today with the greatest inspiration, so that they may share the most knowledge their hearts and given to them. We also pray that you, oh God, grant all participants the understanding to absorb the invaluable knowledge that will be shared today, and for us to put it into practice, that it may be beneficial to our clients. Even as, oh God, we go through this day, we know that you are with us and you take us through to a successful end. At the end of everything, oh God, we will come back to give glory to you. We thank you, Lord. We bless you. In Jesus' name we pray. Amen.
Amen. Thank you so much, Dr. Boateng, for such a powerful prayer. Next, we would like to invite the Education Subcommittee Chairperson, Optom Siabelo, to give us their welcome remarks. Optom Siabelo, if you can hear me, please give us the welcome remarks. Madam Tanuja, it looks like Optom Siabelo has not connected with the audio, so if you can help us with the welcome remarks, it would be grateful.
Sure. Good evening once again. It's an honor to invite you all for the BOA webinar series. It's mostly towards case discussions, and this is our 4th series in the 5th month, and we have 2 international speakers, Professor Vanessa Moodley from South Africa, and also we have, of course, we'll give the detailed introduction that will follow, and we also have the president of Maha Optometry Association from India. Both of them are very good in their specialty contact lenses, so it will be great to hear from them. The great experiences and wisdom and advice and practical tips how to go about, especially when it comes to contact lens fitting in keratoconus and scleral lens fitting. So over to you, moderator. I'm sure you'll take through the session very well.
Sure. Thank you so much. Thank you so much, Madam Tanuja. Next, we want to invite the Vice Chairperson, Optom Tato, to give us the introduction of our first speaker for today.
No,
Tato, can you hear me? Yes. Yeah. So
yes, I
We
can
hear you, sir.
you can start with the introduction of our first speaker. Thank you.
Oh, okay. Thank you, and good evening, everyone. My name is Optom, and I'll be introducing our first speaker for today. Our first speaker, he's a dynamic and a very accomplished optometrist. He has a very extensive experience in specialty contact lens fitting and private practice. Hello? Okay, let me start it from the top. He's a dynamic and accomplished optometrist with extensive experience in specialty contact lens fitting and private practice. He has a proven record of leadership as the president of sorry for that.
Madam Tanuja, please, if you can mute those with the open mic, we'll be grateful. Yeah, thank you so much.
Okay, thank you. He has a proven record of leadership as president of. Okay, thank you. He has a proven track record of leadership as president of the Maharashtra Optometrists Association. In addition to that, he's been recognized for expertise in keratoconus management and commitment to advancing optometry education. He's a former lecturer at prestigious institutions and consulting optometrists at renowned hospitals. As a specialty contact lens practitioner, he worked at a private practice in Mumbai, India, and as a consulting optometrist, he worked in Nanavati Hospital, Mumbai, India, where he collaborated with ophthalmologists to provide pre and post operative care for patients. He managed a diverse range of ocular conditions and diseases. At the School of Optometry or Municipal Eye Hospital in Mumbai, India, he served there as a lecturer, and also at the idea.
Tato, are you there?
Benjamin, Optom Benjamin, I believe his network
Yeah.
is quite poor. Do you
Looks
want me
like,
to
yeah.
continue from where he left?
Yes, sure.
Okay.
So
Professor Kishore Bhandary is basically an optometrist from Mumbai, and he's been serving Maharashtra state from India for a period of over ages 20 to 25, I think even beyond that. And he's been heading the School of Optometry at Municipal Eye Hospital, as well as Aditya Jyoti Institute of Optometry. He's been an external examiner at Nasik College of Optometry. He's been mentor to various kind of students, and even he's trained few ophthalmologists at Nanavati Hospital, and his line of interest is specialty contact lenses. Currently, he's serving Maha Optometry Association, the huge association in Maharashtra, Mumbai, India. He's the president of the association and supported by his elected team. And he's also a very close friend of mine. It is an honor to have you, sir. And I thought I would give an opportunity for the vice chair to introduce you, but it is apologies that his network is not helping him much, but probably he'll join us soon. Over to you, our moderator.
all right, thank you so much, Madam Tanuja. So, Professor Brandy, this is your floor now. We are grateful to have you, and the seminar can start. Dr. Bhandary, we are waiting for you. Your video is muted. If you can unmute yourself and begin, we would be grateful.
Is my screen visible? Am I audible to
Yes.
all?
Yes,
Yes,
you're
the screen is visible. Yeah, we can see and hear you.
Good evening, everyone. Also thank BO as well as Tanuja for giving me a kind introduction. And it was also an opportunity for me because since I'm more into specialty contact lenses, that I do a lot of RGPs and sclerals, I get a lot of keratoconus patients, which is there. And I probably thought of sharing my views and having a discussion with you all. It will be like an open discussion where I will be asking you all something. So when I would like the audience also to be participating in it. So where it will be an open discussion regarding as far as the case discussion is concerned. So this was an unique case of mine, which came to me automatically because what had happened is the family, the father and mother had come for a checkup along with the daughter. The father wanted to do a checkup. The mother also wanted to do a checkup. And the daughter was sitting in one corner, sitting with the mobile and watching. Am I audible or is it still? Should I
Please
continue?
go ahead. Please go ahead.
So-
We can hear you.
Yeah, so we can hear you. Please start with your presentation, slideshow.
Okay. See, basically the patient, the parents had come along with the daughter to the case. I saw this case. So I checked the parents. Both parents were myopic. Since both parents were myopic, I asked the father and mother to why don't you check the child? So the daughters immediately said, I don't have any problems. I've just come as a to accompany my father and mother. And I said, let's check it out. But when I was doing the checkup of the parents, I observed the child. The child was constantly rubbing eyes, sitting in one corner, and plus she had also something like a skin infection called atopic dermatitis. So what I did is I examined the child. So on examination, the initial examination, when I saw the vision was the right eye was about 6.9 and the left eye was about 6.6. So I immediately thought is basically probably there was something, a small refractive error. Probably the father was myopic, mother was myopic. Probably it may be because there is a 95% chance of the child being myopic. So what I did, the first weapon which I used was my retinoscope because that was my main anything which I want to do. I don't put in any auto ref or anything. I just use a retinoscope. So on retinoscope, I found out that the right eye showed a seizure movement as well as the left eye. So that confirmed my diagnosis. Definitely this patient has got keratoconus. But since the vision was almost normal, so what I did is I just prescribed the glasses. And the right eye body was a minus 0.75 cylinder and the left eye plane, and I called them for after 1 month for further evaluation.
So sorry to disturb. So can you start with your slideshow so we can see your slides?
Sorry. Okay. So this was the patient background. Patient came with the, this is what I told you just now. The patient was constantly sitting on mobile, and constantly rubbing eyes. But when I examined the child, so the vision, after 1 month, 1.5 months or 2 months, the patient came back with the broken glasses. So that time when I checked the vision, what the right eye vision was 660 and 636. All of a sudden, there was a drop in the vision, which immediately confirmed my diagnosis. But even then, I had informed the parents earlier, so there may be a problem regarding as far as keratoconus is concerned, with the understanding that later on we'll be doing corneal topography or whatever the examination to be done. So when I checked it again, the right eye refraction was minus 3.25 and the left eye was minus 1.75 with 0.7590, but the right eye was not improving. It was only improving to 680. Immediately what struck me was to take a Placido disc. This is one of the best weapons in optometry practice. If you don't have a corneal topograph or anything, you just take a corneal Placido disc. Immediately you will come to know that whether the patient has got keratoconus. So immediately when I put the Placido disc with the plus 10 diopters behind, the corneal shape was irregular. I did a keratometry, right eye couldn't get any readings, left eye could get some readings. So even then, what I did is what I examined the patient further, and these were the things which I did. The first thing, the equipment which I said was retinoscope. Then I did a placido disc examination, which definitely confirmed my diagnosis. Then I did a color vision test. So always, hello? Color vision test, which we normally need in every patient of a keratoconus. Always remember that color vision test also has to be done. Since the patient was constantly having this problem of itching and rubbing, I also did a Schirmer's test. Schirmer's test also showed that the patient had got dryness. Then
Tomorrow, can I plant that one?
Can you
hear me?
unmute, sir?
The
Yeah, now we can hear you.
Strawberry. Have you got the bucket?
Madam Tanuja, if you can mute the
At
people
the
with
back.
their mics
The
open,
manure, sorry.
help
The
it.
manure is over. Yeah. Okay, I'll bring another one anyway, but you should mix it all together. Once you mix it, and then
We request all of you to mute your system.
Madam Tanuja, can you please mute them? I think since you are the host, you can mute them from
Yeah, I
your-
had to trace them and then mute. Otherwise, I'll land up muting all. So the speaker will get affected.
Oh.
So I'm just trying to trace. Yeah.
Okay.
Professor Bhandary, you can continue.
so these are the equipments which are normally used when I examine a patient, any general patient when I use. This was retinoscope. Retinoscope confirmed my diagnosis. Then keratometer also confirmed. And also one more thing which I understood was I did a Schirmer's test, because normally in all keratoconus patients always think about dry eyes. So the Schirmer's test also confirmed positive. Then the only solution for me is in order to confirm it fully, what I did a corneal topographer. So this is the corneal topographer of both the eyes. So there it is, where it shows the readings which is there. If you see the right eye, the reading shows is almost at about, the simulated K shows about 53.01, and the left eye, the K1, the steep K shows about 53.01, and the flat K 49.95. But when you look at the central 4 millimeters zone, you see the keratometer reading is almost about 56.62 diopters and 50.75. So there was a vast difference about an astigmatism about a 5.87. So there was a vast difference in the keratometry readings which was there, which definitely confirmed my diagnosis of the right eye. Left eye also showed a reading of which is almost about 46.76 and 45.75. But this part of it, which shows basically what I saw is in the first, this doesn't look like more of like a keratoconus. So, but this right eye definitely shows a keratoconus. Next. Even if you see the pachymetry part of it, which is there, the pachymetry readings are also slightly below normal, or whatever you call it is. It's 1 second. It just gives me a reading about pachymetry readings were about 435 in the right eye and about 496 in the left eye. But then see, if you see this here, it always shows an 80% case of a keratoconus. Left eye. Next. The same thing is there where it shows a 59%. So looking at these findings, I definitely found out that the right eye has got keratoconus and the left eye is in the form of a palm first keratoconus. So what I did is, I normally, when I do a corneal topographer, I advise to refer it to a sonologist, or there's a consultant ophthalmics sonologist who does only this the corneal topography, and these are the readings which is there. So if you see the impression, left-sided irregular astigmatism, relative perimetry and posterior corneal suggestive of form first, and right-sided shows definitely keratoconus. Next, now what are the options left for me in case of this patient? So I had about 5 options to decide. Either to give spectacles and just leave it alone, or think about giving her lenses like an RGP lens, soft toric, scleral, or do a corneal cross-linking. So the first choice of spectacles didn't work because the vision was not improving. The second choice of RGP also I didn't think, because she was an avid trekker, which used to always go for trekking and all, and she also plays basketball. So if I give an RGP lens, vision will definitely improve, but the problem is what? The lens may pop out. Soft toric I didn't give because the reason being is because the eye was dry, so I was always looking for dryness. The only option left for me is scleral lenses. Corneal cloth shrinking, reason why I didn't suggest immediately because I thought probably if with the scleral lenses the vision improves, we immediately, probably if after 6 months down the line, if the corneal curvature changes, then we would advise corneal cloth shrinking. So I started going ahead with the scleral lenses. Next. So normally for scleral lenses, for any keratoconus patients, scleral lens is an ideal choice. The reason being is what? There's a normal saline placed in between the cornea and the lens so that it maintains the integrity of the cornea. Next. Next slide. So when we do a slitting, see, I'm not going to the showing you the scleral fitting patterns or something, what we need, and when we do as far as scleral fitting pattern is concerned. What we need basically is, we need a corneal clearance. The cornea has to be clear of everything from all the things. Second thing is what we need a limbal clearance, scleral alignment, and wall top. Means what do you mean by this? Basically, the lens has to be fitted on the cornea very well. So once it fits, there should not be any staining on any cornea or anything. That's the concept of fitting of a scleral lenses. Next. Asit, next. So this is the lens scleral fitting photograph which I have here. So if you see when the patient looks down, you can see the sign here, Munson sign which is there. So this is the way it has been fitted. This when she looks up, so there's no sign of any vascularization or any redness which is there. This is at the sides when she looks at the left hand side. Next. See, basically these are different directions and with different positions which I have taken it as far as the fitting of the contact lens is concerned. And as far as the diameter is concerned, what did I do is I measured the iris diameter from year to year. So depending on the iris diameter, I ordered a contact lens on the basis of that, and then I gave a trial, and this was the fitting of the lens which was there. Next. So these are the fitting, this thing which is done, where if you see in both the eyes, in the right eye especially, and this is the stain. Basically, see, this is what I do with the fluorescein. See, what happens is when you fit a lens, basically, fluorescein has always to be used when you put a lens on the cornea, because without fluorescein, you don't come to know how the fitting works. So in this case, this is the fluorescein pattern which I observed when I did the fitting of the lens. Next. This was the final prescription which I given, which was an 8.0 minus 3.25, 60 in the lens thickness. Left eye didn't prescribe glasses because left eye the vision was improved and both eyes improved to 6.6. The only consideration when I given the scleral lenses, because I was looking from 2 points of view, is basically the patients had a skin infection. So that was one point of view which I was always wondering where the patient is going to itch the eye or something. Since we are putting normal saline in the eye, so the itching may not be so much. And I had earlier treated the patient for blepharitis also. So this was my final prescription. This is what the lens which I had given to the patient. And the patient was wearing it comfortably. Now, the main thing is what as far as lens maintenance and care is there. Because see, the fitting pattern is very easy to fit the patient. Once you give the patient, everything is done from your side. But the maintenance and care has to be done by the patient, because most of the patients which is there sometimes don't maintain the lenses. Basically, they don't clean, the solution is not there, or probably somewhere or the other they create a mistake, and sometimes there's an air bubble which is. So this part is the main part as far as fitting in. So every lens which has to be there has to be clean. It has to be put with normal saline, then inserted the eye. Even when you're removing it, again clean with the solution, again probably soak it in the solution. So this is the normal scleral lens care and maintenance when we give to any patient who wears a scleral lenses. Next. Now, as far as fitting the patient is concerned, the biggest take-home message is what? Take-home message is what? Is basically monitor patients every 6 months. That's the first thing which is there. Whenever a patient comes for a follow-up, always remember that, remove the lenses, see the cornea if there's no staining. Because that's the main part. Because sometimes what happens is patient is wearing the lens, you don't know what's happening to the cornea. So always check the cornea, because if there's any staining is there, or if there's any problem with the fitting, so then adjust the fitting accordingly. And also the main part is also ask the patient how they are putting the lenses, whether they are cleaning the lens with the solution, Because most of the patients whom I have seen is sometimes if they don't have 7, they don't even put the lens, they put it with the soaking solution inside the eye. So these factors are always to be taken into consideration when you fit the lens as far as scleral lens is concerned. So now the forum is open for open discussion. I would like to ask if anybody has got any questions, you can ask me. Thank you. Hope I have not gone fast or something like that.
Thank you so much. That was quick. We are so grateful. Please, if you have any questions, you can put them in the chat, and Dr. Bhandary will address them. Any questions, please? If there are any questions, you can unmute yourself and just ask straight away.
Yeah, you can ask me straight away. That's all. Anything on scleral lenses, anything on fitting, anything how to do it, how do you go about fitting? What do you see in a scleral lenses? See, scleral lenses was one lens where even in an opacity, because I had a case of opacity which improved very well as far as scleral lenses is concerned. So you can fit a scleral lens where an opacity, corneal opacity can also be improved with the help of scleral lenses.
Hi, Doc. There are some questions in the chat box. The first one is, color vision. Why is color vision important in keratoconus?
Definitely, because see, basically, in case of a keratoconus patient, normally, first of all, understand that it's a cornea. So when it's a cornea, first of all, your contrast sensitivity also is less compared to that. Color vision is important to find out if any other defects are there as far as color. That's the reason why I was looking for color vision, because suppose if you find that color vision which was there probably present defective since birth only, so then we look at the other side of it, whether it's to be treated or not. So that's why color vision is a part of the routine as far as examination is concerned.
Okay, thank you. The second one is, after how many days of infection scleral lens was fitted? I don't know how to make of that sentence, but
see, probably he might be talking about, the patient had blepharitis. Probably, see, what is it? When I examined the patient had blepharitis and the patient had dry eyes. So normally what I do is I initially treat the patient for blepharitis and dry eyes. Once it is okay, then I go fit it. So probably after a week or 10 days, I examine the patient, then I fit the lenses. That is the normal routine. And if any infection, you mean to say what type of infection? I'm not sure. What is it?
Okay. The next one says, the next person wants to know if that was the mini scleral lens and which brand it is.
This is a Boston scleral lenses. This is not mini scleral. This is almost about a 16 diopter lens which I fitted with the Boston scleral lenses.
All right, thank you. The next question says, how long do scleral lenses last, and how do I know I should replace them?
Scleral lenses, actually, to look at it, patient wants a scleral lenses, patient doesn't land up in a clinic, even if you call them for a follow-up. So most of the cases where I've given scleral lenses, patient do use it for at least about 2 to 3 years. Except with the lenses badly scratched or something of anything, when they find that the lens is not able to wear or something like that, then the patient comes to you. Normally, the best advice is for a scleral lenses patients to at least change at least in 1.5 years. That's a normal protocol which we follow as far as scleral lenses. But most of the patients don't turn up and change the lens because since it is expensive, that's the reason why they don't land up in the clinic, even after calling them for a follow-up also.
All right. And he also wants to know who cannot wear scleral lenses. If you can give a brief.
Cannot wear scleral lenses.
Yeah. Who cannot wear scleral lenses if they're.
He is talking about the special patient who has lost functionality and can only use the left hand. I can insert the lens, but we have to figure out how she can use it. That one, or what is the question? Which one it?
Yeah, that was just the question. Who cannot wear scleral lenses? Probably maybe some conditions and any exclusive criteria during
See, most of the cases basically, see, the scleral lenses are basically in very severe patients whose corneal thickness is very, I see basically what I was thinking is, I have tried in most of the cases and it has worked wonders, but there are certain cases where I feel like I've got one case where the corneal thickness was very low. So I didn't try any scleral lens because the moment I put that scleral lenses on the eye, the patient used to get real severe pain in the eye. So I immediately stopped where I advised to not to wear scleral lenses because she was very comfortable with an RGP lenses. So I don't know what's the reason behind it because she was an RGB fitter, but I said probably since she was an RGB fitter, probably because of the foreign body going in the eye and aberrations, which I thought of fitting her a scleral lenses, but it didn't work out. So it in those, so it is not that key. Every case will work out with scleral lenses. It is up to you to first try the lenses and see if the patient can tolerate it, if you can get good vision, and then work around it. Because probably for me, every patient is like a challenge for me. It's not like a particular patient who can't wear a lens. And as far as this special patient who can't wear this, the best advice is what? If somebody in the house who's there can teach, if you can teach somebody in the house to wear a scleral lenses. Or probably use the left hand how to put the lenses. That's the other way of doing it. Because teach him how to put it with left hand how to put the lenses. See, or someone in the family can be taught how to put the scleral lenses.
Okay. Dr. Barak wants some tips. He has a special patient who has lost functionality in the right eye and can only use the left. He can insert some scleral lens in a consulting room, but they are yet to figure out how she can use it at on her own at home. So he wants some tips. Any tips? If you have any tips for him, he will be great.
There are special what do you call it, special instruments like this where which has got a light with it and where you can put the lens there, and probably somebody else means some help can be taken from somebody in the house or some family member who is there who can just invert the lens and just place it there. So automatically the lens will be centered inside the, or any family member can be taught how to insert the lenses.
All right. Now the last one is from Optom wants to know, how do you do fluorescein staining on scleral lenses? He missed out on that.
See, fluorescein staining is initially when you put the lens initially in the eye, that's when you do see the fit, you put fluorescein along with the saline in the eye. Later on, when the patient comes for a follow-up, you can just put it on the upper bulbar area, just put fluorescein and automatically you can come to know where the fluorescein, whether the fluorescein is leaking inside or whether there's any, probably where's any areas of touch. So that's the best way of doing it, checking out with fluorescein. It is just like normally, how do you do a normal RGP lenses or how do you stain the cornea? Normally, how do you stain the cornea? Just putting on top of the lens. So immediately the fluorescein will go inside.
All right. Thank you so much, Doc. That was a wonderful presentation. And thank you for answering all the questions. It looks like some are still coming in. There are 3 more. The first one is, are there any disadvantages of scleral lenses, if you would want us to know? So if you can take that question.
Every lens has got its advantages and disadvantages, depending on what is the treatment and what this thing is called. See, it's not like that scleral lens is only the universal thing which is there. See, every lens has got sometimes some lenses which is there will not work. So you have to look at from patient point. See, you look at every individual patient point of whether can I give a scleral lens. And every time, whenever you see the patient has to be monitored. Doesn't mean that you got a patient with an eye refractive error of -10, -12, but it doesn't work out, just give us scleral lenses. Scleral lenses should be worked on the basis of each one's profession, depending on the power of the patient and depending on the corneal topography, depending on the corneal thickness, depending on that, you try to give us scleral lenses. There's nothing like a disadvantage. See, all lenses, see, like if you're talking about any lens, if you're talking about RGP, every lens has got its advantage and disadvantage. Depending on individual cases, you decide on what is good for the patient.
All right. The next 2 questions, let's take the first one. The first one says, can scleral lenses be worn during various activities such as swimming or other sports?
Scleral lenses can be worn while only thing is the problem is what if any Clear lens is the best lens for swimming, but then only thing is you have to wear a goggle on it. But then the problem is what? If the lens has a tendency to absorb something, then it gets, the problem is then you have to set the lens for polishing. Ideally, what we advise is any patients, most of my patients who wear clear lens do use it for swimming, but then they maintain themselves. But then you have to clean the lens in the hydrogen peroxide solution, which is there moment you come from swimming. So because it has to be cleaned up, because whatever chemical is come in contact with the lens, it has to be cleaned.
Thank you. And Dr. Boateng wants to know, what are some of the common complications you have seen with scleral contact lenses, and how did you manage them?
See, the only patient which I had, I had a patient who had given a lens with the unique case which I had given her about a 14 diameter lens, because when that time the lens manufacturing was talking about 5 years back when I first started my scleral lenses. So that time I had given a local manufacturing company which started manufacturing this mini scleral lenses, which worked wonders in this patient. So then probably because the decay value was very low, so then I thought probably when the patient came for a next follow-up, say after 3 years, she wanted a new pair of lenses. So I tried probably giving a better quality lenses of a better company or better brand which is there. So I've even fitted the lenses with them, but then I found that I could not give that fitting or what I could get in the regular. So that's what, whenever we fit any lenses, any scleral lenses, don't go for any brands or anything. Do your fittings very well. You can try 1 or 2, 3 brands, and then whichever one fits very well, go for it. That is what the concept of fitting of a scleral lens. Because what is happening is sometimes you have a trial set of a particular brand, and sometimes you don't have a particular. I would advise you can ask the company or somebody whoever gives it to ask for those lenses also. So fit those lenses. Or see, my protocol of working with the scleral lens fitting is what? When I give a trial, I normally give the lens to the patient and tell them to come after 3-4 hours to see what's happening to the cornea. That's a normal standard protocol of fitting a scleral lens. See, because in your clinic, if you make the patient sit for half an hour to 1 hour, you may not know what's happening to the cornea. So the best way is what? To give a lens or probably switch the lens in the morning, call the patient by 3 o'clock, 4 o'clock, and then evaluate the fitting. That's a better way of doing it.
Okay, thank you. The next one wants to know if you practice impression 3D scleral lenses.
I do know about this impression 3D lenses, but then since the lenses are very expensive, patients in a country like India where affordability is a cost. See, affordability is a cost, so that's what I've never started on this. But probably in future, I might go shift to 3D lenses.
Okay, thank you so much. I think we have come to the end of the questions. The rest of the comments in the chats are just comments saying thank you so much for such an informative and wonderful presentation you have given us. So it shows how much we are all grateful for the presentation you just gave us. So again, we want to say we are grateful, Doc. Thank you so much.
Thank you very much. Thank you. It's my pleasure of presenting a topic which I could probably present in a simple way, because this was a very small topic with a case presentation, which was a unique case of mine, which was just detected accidentally, because this I would have not detected if I had not done either a Placido disc or, because normally most of our practice, when we do practice, what I've seen is many of our optometrists who is there, they don't do retinoscopy. I would advise all the optometrists whoever is practicing, please see that you practice retinoscopy. If you can practice retinoscopy, most of the things can be done very well. Most of any findings on the cornea, any findings on the general structure of the eye can be immediately detected. So if you can practice retinoscopy instead of just placing the patient on auto-ref, I would advise everyone to practice retinoscopy. It's a very simple. See, I don't have an auto-ref, to be very frank with you. I just do everything refraction, which is there with the help of a plane mirror. Still today, I use a plane mirror. So that's my idea of doing refraction. Thank you very much. Thank you, Tanuja. Thank you, MOA. Thank you, BOA, for allowing me to present this topic. And probably in future, I can come with a lot of, because I've got a lot of things which is there. Because I even fitted a patients with Stevens-Johnson syndrome. I get a lot of patients with Stevens-Johnson syndrome. So I think so probably those patients, probably in future I can think we can think about having a coordination with MOA, Maha Optometry Association, where we can have an exchange of lectures where we can present you a case, a live presentation of keratoconus patients also. If probably if Tanuja and PO can help us in doing that.
Definitely. We would look forward to such a wonderful collaboration. So thank you once again, Doc.
My pleasure, sir. My pleasure.
All right. Next, would invite the chairperson of BOA, Optom Tanuja, to do an introduction of our next international speaker.
Yeah, today is a special day because I've been introducing two professors of optometry, two doctors of optometry. Tato, you missed your part. I would say one is a doctor of retinoscopy, and the other person is a doctor of various committees where education, human rights, and keratoconus is her specialty. Okay, we have Professor Vanessa Moodley from South Africa. She's a doctorate in optometry from University of Dublin, and she did a master's and bachelor's from University of Durban, South Africa. She's also currently the associate professor of University of Kwazulu Natal, external examiner for University of Joburg. As I mentioned, we have two doctors of optometry, two professors, two external examiners here, and specialty contact lens people. She's currently the Ocular Therapeutics Program Coordinator for University of KwaZulu-Natal, Durban, International Program Coordinator for the University of KwaZulu-Natal in partnership with US, India, Sweden, France, and Australia. She also conducted workshops for 3 Lebanese University for curriculum development. And part of Education Subcommittee of World Council of Optometry. She's previously the committee member for LRS Legislation Committee of World Council of Optometry, and she is the trustee founder of Keratoconus Foundation of South Africa. She served as the professional board on the professional board for Optometry Health Profession Council of South Africa, and also executive member as an executive member of African Council of Optometry at and also an educator, South African optometry educator at South African Optometric Association. She received Distinguished Service Awards from South African Optometry Association. And she also got a life fellowship honor from Optometry Association of India for her contribution towards development of optometric service in India. I'm sure Professor Dr. Bhandary is noting this because future collaborations, we should involve her in our future collaboration, even with Maha Optometry Association. She also is a recipient of service awards from Health Profession Council of South Africa. She has various publications. It's a long list of 44 publications in various journals, including the African journals. And she's known for her poster presentation at international forums, including USA. And she's author of various articles. And I think she's fond of not only contact lenses, but also binocular vision and very soft-spoken personality. And knows her way around, especially when she lays down principles in various committees like the Education Committee and the Legislation Committee of World Council. I believe she's the one who was on board of the committee to develop the tool for LRS committee, and which we have been seeing through the World Council News, Council of Optometry News. And I should not forget about optometry education. She's an asset for optometry education, curriculum development, and she loves ethics and patient rights. So that makes us all smile. Here we have Professor Moodley. Over to you, ma'am. You've been with us before as a panelist last year during World Sight Month, and we are great to have you again. Here we go. Over to you, ma'am.
Thank you, Tanuja. Let me share my screen with you. There's something going on, is there? I'm going to reshare this thing because it's saying that something is stopping the sharing of it.
It does show that it has started sharing. Probably you want to continue? Because we have multiple people.
Are you seeing the slides though?
No, only Professor Moodley has started screen sharing, only those lines.
Yeah, this is very weird. It's never happened before. Let me just try again. I'm going to stop share. I'm going to, just give me a minute, please. I just want to see what's going on here.
Sure, ma'am.
Let me just put this camera off.
Yeah, we can
Is
see.
that better?
Yes.
Okay, good.
You need to go on.
Oh, sorry. That's the. Are you able to see that?
Yes, ma'am. We can see this slide.
Okay, great. Is that okay?
Not really. You can just see the top right corner of your screen. It's just top right corner, not the whole slide.
There has to be a gremlin, guys. I'm really sorry. I'm actually trying to work out what on earth is going here now because I've shared. Let's do it once more. Is that working?
Yeah, this is full screen. Yes.
Full screen. Great stuff. Okay. Good evening, everyone. I'm sorry, but something seemed to have crept in there. Thank you, Tanuja, and thank you for the BOA for the invitation. Thank you for the wonderful introduction as well. And I am glad to be back with you. I know previously we did have a panel discussion. So I decided after having had a brief discussion with Tanuja earlier on in the week, is that, one of the challenges that we've been having here
Professor
in South
Moodley,
Africa.
I'm sorry to interrupt. The
Yes.
slide is still too zoomed in. Looks like we are zoomed in. So if you can zoom out a bit, so you can see the whole slide.
Is it zoomed in?
Yeah, it looks like we are
Perfect. All right, it's visible.
I think you can continue, ma'am. It's fine.
You can continue. It is fine.
Is it? Oh, okay. Sorry, I was just wondering now, is there something else going on? Thank you, Naomi. Yeah, I was having had a chat and having just reflected on the keratoconus work that we've been doing maybe in the last few years. The one thing we have come to realize is that we're not able to practice like many countries abroad, because for every 100 patients that we are seeing in the hospital, at least 90 of those patients are unable to get hybrid lenses and scleral lenses, etc. So the challenge that we have is that we have to then ask ourselves, what's the most cost-effective treatment options that we in our practices and maybe you in your practices can offer? So I was just hoping that I'm not going to go off the mark by having to say, can we work out that if we take the kind of populations from the countries that we come with, what would be the most relevant, cost-effective approach for the majority of our patients that we have? So I know you all know about keratoconus. One of the things, Dennis, if you don't mind, would you mute yourself? Thank you. Okay, so I know that we're all, hopefully everyone's aware of it, but the reason I thought I would just, let's go back a step or two, because some of the things that we may be doing wrong in our context is we may be missing children. We may be saying, well, I don't do keratoconus because I don't have sophisticated equipment in my practice. And I'm hoping that by the end of my presentation, that each of us on the platform, whether we find we just have a few pieces of equipment or not, we're still going to be able to manage our patients as they deserve to be managed. So, because historically, we were told that keratoconus is a condition that we may not see so often in our practices. We know it's bilateral. It starts in one eye first, and it has progressed quite a bit before somebody pitches up in our practice to say that I have a problem. Because it's asymmetric and it starts in an eye, they continue to function. The child goes to school and they're okay until the other eye starts to deteriorate, and then they seek problems. So then it means that there's something that we have to intervene on. It is self-limiting, it stops, it's affecting more and more young children. I have studies so far coming out of Zimbabwe and other countries, and we're finding the children are much younger. They're 6 years old. When I was a student, I was told, well, it affects them in their early 20s or late teens or early 20s. It doesn't happen that way. We're seeing from 6-year-old to 10-year-old a lot more. The recent study in Kenya found many children that were under 12 that have keratoconus. So we have to have a rethink about this particular disease, because we know that it's genetic, but the triggers, the environmental triggers, are obviously getting to be more prevalent in all our countries. And even if we're in India, we have warm climates, and somehow the environmental triggers are becoming more, and the allergies and associated eye rubbing. So I'd like to start off by saying, can we debunk and get rid in our literature? And I know all the textbooks and the journal articles have been saying that keratoconus is rare. We know that it's not a rare condition. We know that if we are able to diagnose and identify the disease properly, we will actually change the narrative and say that keratoconus is a disease that's no longer rare, specifically in our kind of countries that we are all working in. And then the other thing is that, you know, historically, again, we learned that it's a non-inflammatory disease, but there's ample evidence now. I was in a keratoconus meeting in Dubai 3 weeks ago by the International Keratoconus Society. And the one thing that came out very clear again is that the inflammatory reactions associated with keratoconus cannot anymore be denied. So we know that even ourselves, we've been writing articles and say keratoconus is a bilateral, asymmetric, non-inflammatory disease. But today, if there's anything that we can take home, is that inflammatory markers have been found. The disease does have an inflammatory link, and that we need to be able to treat these children in conjunction with whoever. If you don't treat inflammation in the practice, then at least we know we refer so that we can co-manage our patients, okay? Because our studies are showing regional variations. The prevalence is increasing a lot in the Middle East and Southern Hemisphere, and we are seeing younger and younger children. Just to give you a little bit of a background, we do have various studies going on at the moment, and fortunately, they're increasing quite significantly in Africa. We have a study to our previous speaker, Dr. Bhandary. We have a study right now in Mumbai where 3,800 children have been screened, and the data is being analyzed from there. And indeed, we're finding that the prevalence is quite high. So we cannot treat keratoconus as it is in our individual practices. We have to understand that keratoconus is now becoming a public health problem, and we need to have a public health approach to the disease. So we have to identify children even before they come into our practices. So how many of us on the platform, I'm sure, sometimes go out and we screen. And Dr. Bhandary said that, look, you need to all be good at retinoscopy. And I want to reinforce that. I want to support it, and I want to reinforce it. Because if you as an individual practitioner goes out into into the community, and you have wonderful programs, and I know Tanuja and her team do excellent work. I often see that through either international nonprofit organizations or your association, they go out and they're screening children. But if they're screening children, how many keratochronic children have we know that we are referring? How many are we saying are at risk of keratoconus? So I want to show you that we have a keratoconus risk investigation survey. And that survey gets taken out to schools and it's completed by the child, or the child takes it home and the parents. And I've just put a few questions for you as samples as to what it contains. Things like, who else? We know that there is a very strong family history. There's association with family history for keratoconus. We know that if they rub their eyes, the significance of the correlations of eye rubbing has been found to be statistically significant. We know that if parents are related to each other, consanguinity is very high. And we're having in countries like in the Middle East and in countries where certain cultures allow that, parents are able to marry relatives. So we're finding that the children have a higher prevalence of keratoconus, a little higher than if they have other risk factors. So if you're a practitioner, and even if you practice in private, you need to be aware of what is it that the risks are that's causing this disease to increase, and how are you going to educate your patients. So I would like to just highlight some of the risk factors for you, and to tell you that there is a survey that, you could make your own, or you could utilize, you could ask us for it, but you could use that to find the risks and how many children in your community have risks for keratoconus. So just a case consideration is that if you are screening at a local school and you need to send children who are suspected of keratoconus, you can just unmute quickly. And if you tell me that of all the things that you know when you're going out screening in your teams, which criteria do you use when you want to refer children with keratoconus? What is it that you've picked up? Is it just visual acuity? Because how do we know we're referring for keratoconus as opposed to any other disease? Is there any of you on the platform who does vision screening out? And if you have been referring for keratoconus, what criteria have you been using? Please unmute, feel free. I hope that we can, have nice discussions amongst ourselves. But is there anybody that does screening? And what is it that you have been utilizing to refer? Lebogang, are you unmuting? You're going to tell us? Anyone? Have you, is there anyone on the platform that does a lot of screening in schools? Nobody?
If I may add, mostly they come with, apart from the visual defect, but some can have normal vision to an extent. But eye rubbing and recurrent allergy is one of the things we have found in the screening.
Very good. That's fine, because, there's a strong correlation between VKC and keratoconus. Now, there's a debate as to whether, the eye rubbing is the real problem, or is it really the allergy and the VKC, and which is coming first, and chicken and egg debates are going on at the moment. But we just need to know that if you're going out screening, we need to be able to make the teachers aware that if there's a child who rubs their eyes, and particularly they see them with their knuckles rubbing their eyes, that's a red flag for us. But if they also have allergies, as Tanuja said, allergies and VKC, there has been a close correlation with that. Manish, I think you want to share something with us?
Yeah, usually with screenings, if you're finding with the retinoscopy that there's a high cylinder with Caesar reflex, which can be, yeah.
Yeah, so I think, thank you for that, Manish. And I think that my point, before we move on to the diagnosis, my point from the risk factors and the screening is that if you're going out screening, please carry the retinoscope. please look out for a scissor reflex, because the retinoscope is such an important, I know, as we become, there's autorefractors are out, and you may just take an autoref and you go out and you screen, but it doesn't give you the information that that we get with our retinoscope, because in many instances, keratoconus may not have reached the front of the cornea as yet. So we're not picking it up in the front, even if we have a handheld topographer. It's starting at the back. So because it's starting at the back, we'd be able to then, our retinoscope would be able to pick it up. So please, if I can just encourage that before we even start with the diagnosis of the disease, let's get the screening and let's get the history as well as the risk factors. If you're living in an area that is extremely hot and extremely dusty, and there's lots of, the kids are always having allergies, maybe tell the school nurse or the clinic nurse that when these children come and they're rubbing their eyes and they have a lot of VKC, don't give them the medication and keep sending them. Send them to an optometrist or to an optometry clinic and have the, let them be at least screened for things such as keratoconus, okay? Because we, in our practice, you have a general approach. You do your case history, you do your risk assessments, you do the diagnosis, and I will go through just a few of these with you now, and then you make management decisions. But that is already when they've come to your practice. And because of the need for us to prevent it and to work on the prevalence of this disease, it is also important for us to say what happens before they walk through my practice door and be involved at that level, okay? So we find that the case, once they get to you, your case history will also explore some of the things that we spoke about when we spoke about risk factors, etc. Because when you talk to them about vision, yes, they may be able to see, because perhaps the other eye is either formed first or it's in a very early stage, the vision is still good. But we also may find that they tend to screw their eyes up, and because they're screwing their eyes up and creating their own little pinholes, we find that they can read, but we're not interested in the fact, can you read? We also want to know the quality of your vision. We want to explore whether they're experiencing something called ghosting because of the monocular diplopia that a keratoconic patient will have. Because of the cone, they experience monocular diplopia, not the binocular diplopia like we get with the strabismus. But here they're experiencing that, and you ask them about what are you experiencing ghosting. Now, if you ask a child about ghosting, they're not going to be able to say, yes, I experience ghosting. So it's always good to have a little picture and to show them, when you look at something, do you see this other shadow image? And they'll be able to then tell you, and that would give you a sense, yes, although they're reading the chart or they can read the letters, but they're experiencing this ghosting due to their monocular diplopia. So the symptoms that they give you, explore it and try to find out the detail of it as well, okay? The onset is important because we want to then work out in our heads as to what's going to be our management strategy. Are they in the progressive stage of the disease, or have they reached a plateau? When did they first notice it? Sometimes, in our country, they would come in with a little packet, and we say like a Checkers packet or a Pick and Pay or whatever your local supermarket is, and they have a whole lot of pairs of spectacles which they're taking out. That is another sign to you something's not right, because they would go to one optometrist down the road, and then their friend will say, no, I've got a better person. He's like also maybe a few shillings or whatever our currency is cheaper. And so they go shopping around. But that's not the problem, because somebody hasn't checked to see whether they have keratoconus. And then you must ask about the family history, and if consanguinity is within the cultural background, you are able to discuss it. There's a link we are finding in our research between socioeconomic status and keratoconus. We find that there are families where they judge it by either parental education or just the general socioeconomic status. In our country, we may say, do you get a government grant? Do you go to a school where they give you it's a food program there? It does give you a sense and whether the child is at a higher risk. And then their optical history. You know, are they changing their spectacles all the time, every 6 months? And they're getting a new pair of spectacles, but the optometrist hasn't as yet decided, well, let me pick up my keratometer and have a look to see, why am I changing? Why is this sill and the axis of the sill changing so often? And then, of course, the medical history. So once they get to you and they're sitting in your chair, there's a battery of tests that you would do. And as I said, the scissor reflex is important, the refraction and the axis determination to see if you're getting maybe an oblique axis. Are you extending the range? Now, I know sometimes I go to places and I speak to optometrists and we run a workshop and they say, well, you know, I don't have. That's why today I decided, I know in the scleral lens presentation, we would have spoken about topography and maybe tomography, etc. But you in your practice, hopefully at least, you know, have a minimum equipment, which might be the keratometer. And then you say, well, I can't really take K readings because I get to the end and it's stuck. So you extend the range. You take a +125 lens from your trial lens set, put it in the front. It gives you an additional 9 diopters. And then you can take a keratometry reading. You can take a K reading for, with that. And that's at least a start. You don't own a topographer. You don't own a tomographer. You don't have an OCT. You don't have a pentacam. It's okay, because the bulk of your fitting, I can guarantee you, you will still be able to take care of the majority of the children by just being able to use your keratometer. But you must be aware that your keratometer takes the central 3 millimeters of the cornea, okay? Sometimes you may look and you see the distorted image, and that may give you a clue, but it does take the central 3. And just to give another tip, is sometimes when you're taking those central 3 millimeters, you may find it's quite flat and unusually flat, and you're suspecting the prescription is high and you're suspecting it. Perhaps the cone has dropped. And because the cone has dropped, you're not picking up. You're picking up the area above the cone with your keratometer, so it's seemingly flat, okay? And that when you put a lens in the eye and you see the fluorescein pattern, you will say, oh, so that's what happened. That's why I wondered, why is my K reading so flat? And yet I'm fitting such a steep lens because the cone is fitted slightly lower, okay? So that's just for those of you who have a keratometer in your practice. Please, it's okay, you can make use of it. Do not discard that patient thinking, well, I don't have equipment to be able to do it. If you have a topographer and tomography, wonderful. You can pick up the keratoconus early because it starts at the back of the cornea, and you can pick up the irregularity on the tomographer when you're doing when you look at that. If you don't have it, hopefully you have a good working relationship with some local ophthalmologist, and you can say, please, can you do a tomography for me? And I also want to be able to co-manage my patient that way, okay? You will then do a slit clamp, and if you have a pachymetry, you must know that as the cornea is steepening, cornea is getting thin as well. If you have your slit lamp, you will pick up these signs. Some of these signs are so classic to see. Just a hint, a Fleischer's ring comes up quite early around the base of the cone, but it usually is seen better if you put a cobalt light. Try not to see it with a white light. Put your blue light on, your cobalt light, and you can actually then see the hemosiderin deposit at the base of the cone, and that gives you a sense also about it. But your vertical striae in the posterior stroma, you can, with your regular slit lamp, practice your techniques, increase the magnification. You'll be able to pick these up. The central corneal thinning, you do a good optic section, and you look at the thickness from the top as it's going. You'll find that thin area that, like it is on that slide, and you'll say, okay, this is where I suspect my cone is. Now, another hint, which I often say to the students, just look at your pupil behind that. And then you can see if the cornea on your optic section is thinner towards the bottom, you're already suspecting I'm going to have a decentered cone. So when I'm choosing my lens, my contact lens I'm going to fit, let me go for a little larger diameter because my cone is slightly decentered. So I need a bigger optic area. So you start to join the dots. And all you're doing is you've got a slit lamp, you've got a keratometer, you're not needing anything sophisticated, but you're able to manage your patient. Your Rizzuti sign, you shine the light on the limbal area on the one side, you pick up you see this little cone, the shape that comes up on the end, it gives you an indication. And then, of course, they have to be quite advanced for you to be able to see that cone in essential for Manson signs. So these are just your slit lamp techniques that you're going to practice and you're going to be able to pick up with your keratochronic patients. So whether they came from the school or whether they came from the local clinic or they came from another colleague of yours who says, you know, I think it's keratoconus, I'm sending them to you because I know you do contact lens fitting. You will then just do, I'm not going to go through this because I'm sure you all know, you take the measurements that you will take to be able to work out your lens of first choice. So you'll take your, you know, your measurements horizontally, vertical, palpebral apertures, your photopic and scotopic pupil diameters, and you have to ensure you do all your tear functions tests, your tear breakup time, your Schirmer time, because you want to be able to say, does my patient have an evaporative dry eye? Does my patient have an aqueous deficient dry eye? The majority of keratochronic patients have dry eye. They have allergies. So you can't only manage their vision and leave them with the dry eye, because your contact lens is not even going to wet properly most of the time. And they're going to say that my lens gets blurred a little bit. I don't know, because you manage the keratoconus with the optics, the optical part, but you didn't manage the dry eye. So please, I put this up just to highlight for us, okay, to be able to do that. Okay, so once you've done that, so we're going to be fitting the lens. You're going to have a sense as to the cone and where the cone is and the type of the cone that I have, which is quite important. If you don't have, you know, I often say, if you didn't have the topographer and you're not exactly sure whether I have a nipple cone or an oval cone, or if I have a globus cone, when you pick up your ret, you'd be able to pick up which part is there a faster reflex. Is it more central? Is it a wider area? Or you would be able to, on your slit lamp, you can very easily make out, you look at your patient from the side and you'll be able to see, get a good sense as to what the cone is. You let them look down and you can, using the lower lid. And I want to encourage you, let's look for some simple things to be able to see our patient and to be able to then stage it. Because if I can stage whether I'm dealing with a mild, a moderate, or an advanced keratoconus, I save the chair time that I'm going to have them sitting in my chair, because I won't be starting off with some theoretical formula. I know, okay, I'm dealing with an oval cone. I'm expecting that it's going to be lower. I'm going to know that my K readings are going to be that steep. So staging becomes very important when you're fitting. And then then you'll make a decision. So how am I going to manage the patient? Am I going to fit a pair of spectacles? Am I going to fit a custom soft lenses? I don't know how readily available they might be to you. And you're making another very important decision is, am I going to send this child for cross-linking to the ophthalmologist? Because I've treated their dad, I've treated the older sister, and at that time I didn't really know much about cross-linking, but I don't want this little 6-year-old or 8-year-old to have to get to advanced keratoconus, because maybe one of the children couldn't get a corneal transplant because it was so expensive and they're still sitting with the big scar and had to maybe leave school. So our responsibility is, let's go back and find those children, even in your current practice. Go back tomorrow and look through your records and say, I've seen this little girl for the last 4 years now, and every time I'm increasing her prescription. Is it not time that we send them for corneal cross-linking? So I put that little arrow there to say, even while we're dealing with the type of lens we're going to fit, let's go back and see if there's progression. And if there is progression, then we may not necessarily use this profile here. We may need to find out, what does progression mean? So you might say, so how do I know that he's progressing? You know, maybe he went to some other optometrist before. Find out from them, where did you go? Call the optometrist and say, please, can I have some records for this child? Because I'm trying to determine how much have there been changes And are we in a progressive stage? And can I send this child for cross-linking? Remember, you're not losing a patient. You're sending them for cross-linking. They're being, 3 months later, or maybe 2-3 months later, you're happy, they're stabilized now. They come back to you, you're fitting them with your rigid contact lens again. So it's not about sending the patient off. It's about sending them off to halt the progression of the disease. So this young child is not going to end up progressing and getting corneal scars and having to, because of the scarring, having to find that now lenses are no longer helping because the scars right in front of the pupil. They get put on a transplant list. We have transplant lists here that are so long. We have contact lens lists that are over 200 in some of our public sector hospitals. We want to be able to try to halt that progression. So this child, maybe they'll wear contact lenses for the rest of their life, but their disease will not progress to the stage that they won't be. So increased astigmatism, if it's increasing, every few months, you can find that the axis seems to be orientating and changing quite often. There's a diopter or more of corneal power on the steepest meridian every time you see them, and that the thickness seems to be decreasing by 25 microns. By 25 microns. Right. Okay. So those would be your clues to say that this disease is progressing. Okay. And then I told you we'll consider, then I would go back and say, right, I've done this, it's not progressing, or I've sorted the child out, or maybe it's an older patient who already has plateaued. So then I would look at my cone and I would say, so what are my options? So these are, now in some practices, if you're in South Africa and you're in a high-end practice in Sandton, they don't even look at, oh, well, why must I fit corneal lenses? I will just fit scleral lenses on everybody, no matter how early the disease is, etc. My patients are paying me in our money, maybe 15,000 Rand or something. That's the approach that you take. But I, as Tanuja say, wearing both public health and educator hat and private sector hat, etc., my approach to optometry would be different. So I would say, well, if I look at it, what is it that we could help if it's cost effective? And this would kind of give you a guide that, yes, I can fit a hybrid, I can fit a piggyback lens, I can fit a corneal lens, I can fit a scleral on that child. What helps me make the decision as to which lens I'm going to fit? Maybe the cone. I'd say, okay, with this cone, I can fit a nice small lens. I've got a nipple cone, or I've got a PMD maybe, and I'm going to only be able to go for something larger. A scleral lens is going to be my first option, but your option must be informed by something, both clinical and both demographic profile of the patient that you have before you. So if we're fitting, because I said to you, out of every 100 in our public sector hospital, an eye hospital that we work in, we find 95 of them or so we are fitting with RGP successfully, even if they can have only finger counting when they start, and we're sending them off to go back to school, etc., with 6.6, 6.75 visual acuity. So the approach that we take, it fits the majority of patients in a low income context. And I can actually ask any of you to try to prove me wrong on that and say to me, no, I come from a country that has limited resources and we can't seem to be successful with RGP lenses. I promise you that I will be able to show you how something might not be right in that context, okay? So yes, there's a place for all our hybrids and our scleral lenses, but there is a larger population that we can manage. So you do your trial lens fits. I don't, because of the kind of keratoconic patients that we come across and how irregular the cornea is, and you may have a -15 diopter cell, etc. I don't really encourage empirical fits where you would just punch it in and send it to your lab, and your lab will order make up the decision on the final lens. Why do I say that? Is because the lid dynamics affect the fit of the lens. The patient has a tighter lid. Somebody has a more lax or loose lid. The other one has a tighter lid. The lens is going to fit differently. Someone has more tears in their eye and they have a drier eye. It's going to affect the fit. So the empirical lens that's going to be designed by your lab may not necessarily factor in those types of things, okay? So I just personally, I would prefer the trial lens method rather than the empirical fit method. And as I say, it's worked fine with trial lenses. It just means that you need to have a few trial sets that you buy and keep in your practice, okay? So we consider the cone location, as I said, and then generally we don't want to fit low DK lenses. I remember, because I'm old now, I belong to a time where when I was a student, there was a lot of PMMA lenses being fitted. Today we have the luxury of rigid gas permeable lenses, and we can fit higher DK materials for our patients to ensure that they have adequate oxygen coming through, that they have, we're able to avoid lots of the signs of hypoxia that we find. So there's different fitting strategies, okay? So, and I'm very briefly going to go through these ones with you. So when you're fitting, you will decide, depending on the strategy that you often utilize, but an acceptable RGP strategy is if you fit with a slight apical clearance, if you fit with your 3-point touch, which is quite common, or if you fit with just a little bit of a flat fit on not a very advanced cornea. Please, if it's thin, just try to avoid having this so-called, I know in some countries in Europe, they would say, oh no, we fit a RGP lens. I fit it flatter because I know it can help me push back the cone. I don't believe in that. I worry about the fact that we're going to cause some harm and we're going to have epithelial interaction. So I'm not too keen on that type of thing. So once you have determined it and you've worked out the lens that you're going to fit using your keratometry reading or your topography, that if you have, and when you fit it, remember that you will look at, like with all your RGP fits, you will look at the dynamic fit in white light and your lag and your sag and, you know, how much the lens is moving. Is there adequate tear exchange? But when you want to assess the fluorescein pattern, please do not, my students that do this often, they make a mistake. They would say, oh, the lens is fitting very steep. When I go and have a look, you see that the lens is riding low. And that's why it's looking steep, because it's fitting on the lower part of the cornea, which is the flatter part. So the fluorescein pattern looks very steep down there. You just go in, you put your finger in, and you use the lid, center that lens, and you find it's a perfect fit when it's centered. So which means the problem there is not the base curve of the lens that you fitted in. The problem is that whatever is causing the lens to ride low. So you then may want to say, well, my adjustment is not going to be on the base curve, because when I centered the lens, I had a very good lens-cornea relationship. So I know it's not about the base curve. I know that I may have to change my optic zone or change my diameter to get that lens to center better. So when you're assessing your slit lamp assessment, when you put your fluorescein in, it's very important, okay, that even if you like to fit and you get a nice 3-point touch, whatever, but please make sure that don't assess that if the lens is not centered, because then you're not doing a proper fluorescein assessment of that lens. When you're doing your power over that, once you get your good fit, don't forget a positive tear lens you have. If you fitted apical clearance, you've now got a positive tear lens. The patient may accept a little more minus than you thought originally when you worked out what the lens power should be. And that's because you fitted apical clearance. You got a positive tear lens. So to neutralize that, the patient will accept more minus. If you did a slight touch, you may find it creates a negative tear lens. The patient may accept less minus than you thought. If you thought you were going to prescribe a -9 and now you're getting a -850 or whatever, it could be because you fitted with a little bit of touch and the patient's accepting more plus on that. Just be careful though, again, I want to say, be careful with the touch. We do not want to cause damage to that no epithelial trauma caused by the optometrist. When I was in that meeting, and I think I'd like to share this with you recently, you know, there were very few optometrists and majority ophthalmologists. And at least every few speakers said, we do surgery on these patients, we put Intacs because, you know, because of contact lens intolerance. And I was very worried listening to speaker after speaker saying they do surgery on these children because of contact lens intolerance. I then, you know, when it came to question time, you know, we raised it that I don't know what you mean by contact lens intolerance, because if I fit badly, maybe my patient won't be able to tolerate it. But if I fit an RGP lens, well, why would my patient be intolerant? If there really is sensitivity, maybe I'll fit a piggyback lens. I'll put a soft lens under, or I'll fit a scleral lens. So why is this thing amongst ophthalmologists that there's a lot of contact lens intolerance? That's why they have to do surgery. Now think how invasive it is, because maybe we as optometrists, there's something we're not doing right. So the ophthalmology profession is saying there's a lot of contact lens intolerance. So I just want to throw that out to your association, that I think if we educate our practitioners, and today's is an excellent thing that that the association is doing, because this is what we want to do as a collective. So we don't have professions that our children that are undergoing a lot of surgical procedures like in intrastromal rings, etc., because that's the only way they feel we can correct these patients, because they can't wear contact lenses. And we can have a discussion about that when we get to that. So if we, I just want to just take a case of a 16-year-old patient where the parents were unemployed. And that's why I know you'll have the scleral first, because maybe, I don't know the costs of scleral lenses, but we can get a pair of RGP lenses really cheap in South Africa. And we can make sure that this child whose parents are unemployed will still be able to, even if it's from their government grant, etc., they'll still be able to wear that. Because if he's had reduced vision in one eye and they come to since age 9 and 16 he is now, so he's been gathering pairs of spectacles from everybody that he goes to, and they've been changing it. He has rubbed his eyes, and there's although there's no medication or no known allergies, but he tends to rub his eyes often. And sometimes we mustn't say that rubbing eyes may only become from that, because children have bad habits as well. So just to say why a corneal lens in this instant may have been the option that the child had. So after calculating it, they put a lens in the eye and found that, okay, there was this touch, but there was this big bubble in the mid-peripheral area. So if you, just to give you hints as to the processes that it would go through, if you find that you have a central cone and you put a lens in, and you may find very often you're getting this mid-peripheral pooling, and so steep sometimes that you have a bubble in it. So your options would be to change something so that it gets improved. Sorry, that middle picture, didn't come out so good. But you change something to find that, okay, it's not so steep anymore. I've managed to get reduction in that. I will then make another adjustment before I send it to the adjust to the lab, because I've got a cone which is like the steep top of a hill. If I place a lens over that, you'd expect that there will be pooling over. The issue is that, is it draining out well? Does it seem to stay there? Do I ask my lab to just add a curve, an additional curve? This was a Kleck lens. This was a 3-curved lens. We would then say to the lab, if you look at that last picture, look, just add one more curve in there for me. Make it a 4-curve design. So I flatten just outside of that central area, or I reduce the optic zone diameter. The tears are going in. The fact that there's a little bit of extra tears in one part of the contact lens for a keratoconic patient, don't stress about it, because it's exchanging quite easily, okay? So the lenses that you would fit is maybe initially a 6.3, then you went flatter and flattened in that secondary curve zone as well. And finally, the patient comes back for follow-up, and you find that you've got a fluorescein pattern, which has showed a very slight central touch, little bit of mid-peripheral pooling, no bubbles underneath the lens to show that there's trapped tears anywhere. If you go 360 degrees around the edge, you've got a nice edge lift. Just another hint for you all as well. How do I know that I have a good edge clearance? When you take your slit lamp, put your parallel pipette section, go to the edge and have a look. If you get a positive tear meniscus, that means a little curve outside the tears, then you know that your edge is just right. Because if you have too much of an edge clearance, you will get a negative tear meniscus. So it will, because of the fluid force. If you have too tight, you're going to see the impingement. But if your edge is just right, when you look at the edge of your lens, you will see this nice green pattern, but look on the outside of it, you will see a nice little positive tear meniscus on the outside. Just a hint from experience as to how I got an idea now that my edge is just right, okay? Also, don't be too concerned. If you're fitting a rigid corneal lens and you find that the edge clearance looks a little thicker in one, maybe along one meridian as opposed to the other, it's okay because you've got a highly irregular cornea. So in one part, you may have a little less tears. It's not a problem as long as there's tear exchange going in and out, okay? Your 1.5 millimeters blink. On the aftercare, the patient came back. There's no corneal staining, even where I thought I was worried about a little bit of extra pooling there. But because it's flushing out with every blink, there was no corneal staining. When they come for an aftercare, take out the lens, stain the cornea, look for any areas where you are getting some abrasion. Maybe the lab didn't blend the junction between the second curve and third curve nicely, and suddenly you're finding a slight abrasion. Have a look at it. Look at the lens in the loop with your loop magnifier and say, okay, I don't like this edge. Send it back to the lab and say, look, I asked for a B blend. I don't think this is a B blend. Maybe it's an A. Please blend, put it back on your machine and blend the edge for me, the junctions nicely. I want some pooling to go in, okay? And the visual acuity of the patient is then 6.6. I just want to encourage you that I think, as I say, I don't know, maybe some of you are all in high street practices and you patients walk in and you can fit them with your hybrids, with your sclerals, with your piggyback lenses, and they can afford to pay for it. They have no problem. If you don't practice like that, do not be scared to try rigid corneal lenses, okay? Because sometimes you may have an RGP, you've got an excellent fit, good VA, patient is uncomfortable. You may be saying, okay, I've got no choice now. I'm going to fit a soft lens under this lens. I'm going to create a piggyback lens, or because maybe the hybrid lenses, maybe they're too expensive by the time we import them into the country, or you're finding that you can take a soft disposable contact lens and put it under. If it works, it hasn't affected your visual acuity too much. Normally, if you still haven't decided and you're deciding about fitting a hybrid, you will fit your soft lens, you take K readings over it again, and often it flattens the corneal profile a little. So you'll end up fitting a gas permeable lens, which is about 0.2 flatter than you would have originally fitted without the soft lens under, okay? And remember, you use high molecular weight fluorescein if you're going to keep that lens. If it's a lens that you know it's a monthly lens or something and you want to just check, patient comes in, you want to check something, you buy the high molecular weight fluorescein. I think it's Fluorexon or something it is called, okay? It may be available. If your lens is riding low, which is a common problem with keratochronic patients, then what you do is often you can increase the optic zone diameter, increase your overall diameter, increase your edge lift. You tend to get better centration because that's a very common problem with keratoconus because of the low-lying lenses, okay? So you can, I was hoping somebody can share their cases with us if you like, if there's something, as long as everybody else would not be too tired. And in conclusion, I just want to say that RGP lenses may be the option in Africa still for a long time, until our socioeconomic status changes and all our patients have lots of money. We may have to consider that, yes, we do fit other specialty lenses, and we must know that at some point, the more you fit, the more you buy equipment and you buy yourself a pentacam and a OCT, etc. You would be able to then, your profile of your practice changes. But that doesn't stop the average practitioner who even has a keratometer to be able to treat the child rather than keep giving them spectacles and letting them go off each time, okay? We just need some good knowledge and good skills, and maybe the Botswana Optometry Association can run workshops for practitioners, show them all the different techniques about how you fit good, well-fitted corneal lenses and how the quality of life you are changing for the children that you are managing. So let's get involved in initiatives to find those children as well. So please, outside your practice in the schools, community screening, if you're going through some religious church organization, temple organization, I mean, our churches go out and we do screening in communities, at least go with your retinoscope and a chart, etc., to be able to pick up the children. So let's not let these children, these are children that we've done corneal transplants on as part of a voluntary program. But they had to be found by somebody before we could assist them. So let's remember that we don't want to leave any child behind. I thank you for your attention, and I do hope that I've managed to share some things with you that will be of benefit to you in your practice. Thank you very much.
Thank you very much, Professor Moodley. Thank you for the presentation. It was very informative, especially concerning the cost effectiveness and how we can build confidence to know that no matter the instrumentation we have, we'll be able to do and deliver for the children and even the mid-adults that we meet in our clinics. Thank you very much. We would like to move now to the next stage, which is the Q&A. And anybody who has any question, you can unmute and ask question directly, or you can just type in the chat box and then we'll read out to Professor to give us the response. So the floor is open. Please, if you have any questions, just type it out or just unmute and then ask the question directly. Thank you very much. We have about 10 minutes to wrap up the Q&A session. So over to you, panel, or attendees, I should say.
You're welcome to unmute and ask the question. I'll be happy to take it if you don't feel like fingers are sore. We don't want to write. No problem. You can unmute. And
No, one question, this is Manish Mathur. One question, why the specialty contact lenses, especially for correct keratoconus like scleral lenses, why they are not getting cheaper?
thank you for that, Manish. And I think that's a very good question because we've been engaging with laboratories. In fact, what we're doing right now is we're actually trying to design. We're taking all this data, we're trying to design lenses so that we can look at design sets of lenses that we think are appropriate for the patients we see. We looked at the cost of those scleral lenses. I also just want to say to you that, you know, a cheaper, a larger diameter lens, you can fit, remember, you can even fit an 11.2, etc., without having to go to the scleral lens. When we looked in South Africa, they're companies that make a local scleral lens. I met somebody who owns a laboratory and they work in internationally, but they were saying, you know, they could set up, if they set up a laboratory, it is actually quite cheap to be able to design scleral lenses and to have them locally manufactured. I think the challenge we have in many of our countries is that unfortunately we are using lenses that have been designed internationally. They have their patents, they have their costs that are related to them. But I think for those of us that are in countries that, Manish, and I guess, are you based in Botswana or India? I'm not sure. But if we have to get locally manufactured lenses, so the import costs and the you know the lenses that are available internationally for us are expensive only because they're not manufactured. We find that, you know, with RGP lenses now, they can be manufactured for really cost effectively. So the cost of scleral lenses, I think, are expensive still, and other lenses, mainly because they're not manufactured or designed in our country. So there's a lot, I'm you know, throwing out to all of you here, some of you may want to be able to wear your business hats, and perhaps you have laboratories for spectacles. I don't know if you can try to extend that to design contact lenses that are more cost effective. it's way beyond, you know, most of our patients here cannot walk in and get a pair of scleral lenses. I'm talking about public sector patients, you know, maybe private they can. So the expense comes with it. I don't know if anyone else on the platform will know why it's so expensive. I don't know what you pay in Botswana, and whether with us, what advice would you give in handling these cases? Yes, I would actually, I would give advice. I would tell you firstly that if you just get a little bit skilled on fitting well, normal corneal lenses, 8.6 diameter, keep yourself a set that has get an 8.6 diameter, get a 9.2, and then 9.8 and maybe a 10 or 11 diameter lens sets. You keep these ones, they're very cost effective, very basic. Try and get a 3-curve, a 4-curve, and a 5-curve design lens. And I can tell you, you'll fit the majority of your patients with that. So in our setting, your setting and my setting is similar. So in our setting, let's at least learn how to fit good RGP lenses, but let's not forget there will be those patients who can afford it or who have to have it. I have a PhD student of mine that has just finished and graduated last week or something, and she in her country, which is in Africa, they have fitted lenses on patients who have cones that are like 80. I have my undergraduate students, you know, the K readings are going, they've extended the range, it can't get on their keratometer. I tell them, throw it aside, put a lens in the eye and let's work from there. So they're fitting maybe base curves 4.5, etc. base curves, and that's really steep. But you're having a happy patient walking out with a corneal lens in the eye. So to the delegate who asked, what do we do in our kind of context? My answer to you is let's learn how to fit rigid gas permeable lenses, and let's try and get a few sets of cost-effective lenses. They don't cost too much of money, and learn how to fit them well. And the majority of your patients will be taken care of. If you find something is really difficult, you can't fit a toric. You know, sometimes I would say to the lab, I'm happy with this lens, but I've got too much of pooling at the bottom, you know, at the bottom of the cone, etc. Please put a peripheral curve, a toric curve on the periphery for me. So the lab will put a toric curve, and my patient is happy. But I didn't have to buy them anything fancy. All I did, I asked the lab to put in a curve on the edge for me, on the periphery. And then it comes closer to the cornea, and all those extra tears are gone away. My patient is happy. So it just means that you got to get skilled. So if you can get together and have some workshops and fit lenses and just become good, the majority of your patients will be taken care of with that. And yes, there'll always be a time you want to prescribe to somebody. You can fit 6 over happy and not 6.6. Okay, my suggestion to you is let's try for 6. But 6 over happy makes a very big difference to a patient's quality of life. You're right. If your patient can go back to school. I mean, I had a young boy whose mother said that he used to pass her on the street if she sends him to the store. And on the way back, he would pass her if she's walking, and he won't greet, well, he made a sigh, but not greet her as the mother because he couldn't make her out. And now, with this little thing, she says, with this small thing in his eye, he's actually got the book prize at school. So let alone seeing his mother's face. So I want to say to you that what you do with this, and I'm sure with other diseases in optometry, but it's life-changing to many children who the quality of life extensively changes. We actually do studies on this. You know, we do quality of life questionnaires, and you'll be amazed at the stories that you hear for an optometrist who was just doing our job and fitting a child with the corneal contact lens. Okay. So yes, you can do it.
I have one.
Yes.
Ma'am, can I ask?
Yes, sure.
Myself, Naksen Daune. I'm from India.
Yeah.
Actually, ma'am, as you are suggesting that RGB, but customize as per your experience, that is going to be best for the keratoconus person or patient. But I just want to ask you, means besides to cost factor, which one is means gives more comfortness as long as water content and water means every technical aspect is concerned in comparison with RGP and scleral.
Look, the scleral will give you initially it does give better comfort because remember, it's landing on the sclera. If I put it on, my patient will say, well, that feels really comfortable. But remember, if you fit an RGP lens well, if you ensure that the patient is, the design of the lens is such that your edge, where the discomfort with any RGP, it doesn't have to be keratoconus, it can be any RGP wearer. The discomfort comes from the edge. It comes from the edge profile. Now, I may be fitting a -19. I think last week we had a -19 lens. You will expect that a -19 lens has quite a thick edge. So what my instruction to the lab is, please can you bevel the anterior part of that lens? If everyone can just visualize this, right? We've got an edge that's quite thick. So I know that the lid is going to rub on the edge of that lens. So my instruction to the lab is I'm happy with the posterior part between the cornea and the contact lens. I'm getting a nice edge. But I know the edge of the lens, the top part is going to irritate my patient a bit. So I instruct my lab to bevel the lens for me, to blend it so that anteriorly, because I want a smooth profile over that lens. So the lab polishes the lens well, and the patient blinks over that lens, a -19, and the patient is not complaining of discomfort. It's because of the design of the contact lens. So when you speak to your laboratory, that's why I don't like empirical fits. I don't say to the lab, make the lens. Here's my K reading, here's my power, and there's my patient's measurements. Please design a lens for me. No, I don't. If you're a professional, we don't place the expertise into somebody's hands for a rigid lens. We will then say to the lab, I'm fitting a high power lens and I want them to be comfortable. What you're saying is right. I want my patient to be comfortable. When the patients come back for their 1 week aftercare and I say, so are you aware often of the lens? They say, no, actually now I'm used to the lens. So your question about initial comfort with the scleral is always better. But if you do have some patients that just cannot tolerate it, there will be those patients, but they will be very few. Then you will decide, okay, I'm going to fit a hybrid, I'm going to fit a piggyback, I'm going to fit a scleral lens. And depending on which you choose to fit, I mean, I fit all lenses. So I would then decide on that patient, I think I'm going to go for scleral here, or I think I'm going to. Then there's other conditions where they have PMD, and I can see it so, the peripheral is so steep, I may go straight for a scleral lens then. I decide, okay, look, I'm not going to fit a cornea. Let me go for a scleral lens for this one because I've got such steepening in the periphery. Or if my patient has, Sjogren's, or if my patient has a very, very dry eye, and I know that even with tear supplements, we're going to struggle, I then want the benefit of the scleral lens because the scleral lens is used to manage my dry eye, and it's going to be used to manage that, and my patient can afford it. So then it's not a problem. I would choose it. I think, we mustn't, the issue is that we must just be open to fit. We must have an armament of tools. We must have different designs of lenses in our practices. And we must say, I'm going to choose something that is best for my patient. I'm not going to push something because I feel comfortable or because I like it or because I like this laboratory. I'm going to be able to choose whatever it is that I know is going to match my patient. And when you have a busy clinic with lots of patients of keratoconus or whatever, you find that that's what you do. You then match different patients differently with whatever they have. So I work, in the public sector. We have a hospital. Patients, most of them can't even pay for that basic thing. The hospital has to give it. And then on the other hand, you run a private practice and you find that patients come in and they say, I want the best. So then you would fit it. But I think I would actually disagree if I hear that well, RGPs are just too uncomfortable. Yes, they're uncomfortable in the beginning. So before I put a lens in the patient's eye, I would say to them, I'm going to put this lens in your eye. there's going to be some initial discomfort. Maybe you're going to tear a little bit, but if you just look down initially, blink a few times, when you're feeling a little more comfortable, look straight ahead, you'll find that it will subside. Because I know that my initial trial lens is not so far off that is going to be really uncomfortable. If it is moving all around, you've worked out a very flat lens, take it out and go much steeper, 0.3 or 0.4 steeper, and then you can fit with that. So discomfort, we must manage it.
Can I
Okay,
add
thanks.
one thing
Thank
if you
you.
don't mind?
Yes, Dr. Bhandary.
See,
Prof.
RGP
Bhandary,
is always the first choice in case of any patient who has got problem, because normally scleral lens is the last choice. So even in my case, whenever I fit contact lenses, I always look at RGP as the first choice, because what I've seen is whether the patient when the patient has got keratoconus, when you fit an RGP, whether you put a 9.2 or a 9.6 or a 9.8, whatever diameters, but depending on the condition of the keratoconus, it works wonders basically. And it's matter of time, because moment the patient sees very well, I think so with time, the patient gets used to the lenses, except for the only problem with the RGP lenses, basically if any dust going in the air. That if you can explain to the patient, see, basically it's an explanation from our side to explain to the patient what we are talking about RGP lenses. It is not necessary that we go on to fit on scleral lenses or something like that, because RGP lens is the first choice of any patient who comes for any problems related to the cornea. I would always look into that aspect before I jump into the eye end ranges or something like that. Except suppose if I find that if I'm not able to fit with an RGP, then I would go. And also one more thing, what can be done is, like you said about trial lenses. See, my way of working initially when I started with an RGP lens is what I used to do is basically whatever the keratometer reading is, I used to order those lenses closer to that and fit the lenses. So once I fit the lens closer to that power and this thing, then suppose I find that this lens doesn't work out, so that I keep it as my trial set and then order a new one. That is what the other way of having a trial set. You don't have to buy a full trial set regarding.
Yeah, absolutely. Generally, you're right. You can grow your sets, and the more you fit, the more you have lenses. If something didn't work, you've got it. Maybe the next patient you've got adds to your. Because remember, the way the cone dynamics work, we don't know where their cone is exactly going to land. So it will give us slightly different fit patterns. But the other thing you will become more confident to do is you will be able to fit, because of the high decay materials. In the old days, we didn't have such good materials that are such high decay, where we can fit larger diameter. We can go quite large, and it gives us a stable lens. And we're able to fit, and we're able to just vault all the things that we're concerned about, and the patient is happy. The patient feels more comfortable because we went larger on our diameter as well. Sometimes if it's a little smaller, they're rocking a little bit too much. You can then just try and say, well, look, let me just increase this optic zone. Let me increase the diameter. I'll order a high decay, so I've got nice oxygen through. I've got so you can it becomes an art after a while. And I really, if you're nervous, if you want to start, you can get together, and two of you together can maybe say, okay, can we maybe get together I know we're all competing sometimes, etc., but maybe just saying, let's put our keratochronic patients together, and your practice has got this, and we can fit them together, and we're sharing both our knowledge, etc. But I want to assure you that it's not hard, okay? It sometimes sounds challenging because you get such irregular corneas, but just the more you do it, I mean, my fourth year students, from week 1 to when the end of the term or semester, they suddenly become so good. It's because they're learning all the time, and they're making the mistakes in the beginning. So you may 1 or 2 lenses in the beginning, you don't have you could have made a mistake, but the next time you learned, you won't do the same thing again, okay? I just want to encourage you to try. I want to encourage you to learn, and I want you to encourage you to ask for help if ever you're needing. I think I am done, Tanuja.
Okay, Professor Moodley, thank you very much. And then we thank you for
You're welcome.
the very informative. You can tell from the way you break down the topics that you are teaching, sir. Thank you very much. We really cut along, and then for some of us it's very informative, and then we'll keep the conversation going in terms of problems that we have through our chairperson to you. so that you can assist us at the right time, especially about the workshops that you talked about. We're very interested in that. And then we really, really thank you for this session.
Thank you.
And
thank you, everyone.
to all participants, thank you. Our time is a little bit, we're supposed to knock off at 8, but we're a little bit behind time. So if you have any questions, please put them in the chat box. We will then collate them and then give it to the necessary authorities and get back to you, because we have your email addresses and everything. So please, if you have any further questions, just put them in the chat box and then we will convey to the appropriate authorities. At this point, we would like to invite Optom Dr. Hakeem Afol to give us the vote of thanks. Dr. Afol, if you are online, please take it from here.
Good evening, everyone. Thank you for the introduction. So I am going to be giving the vote of thanks for this lovely program that we've had. First of all, I would like to say thank you to everyone who took the time to listen to this webinar, this case discussion, to everyone who took the time to present. We want to say a big thank you to all of you. So first of all, I would like to express our deepest gratitude to our program directors, Dr. Atta and Dr. Barak, for their organization to make this program a success and their direction. We thank you very much for that. A special thank you to Dr. Watson as well for the opening prayer. Your words really set the tone for the program and for the success of it, and for us to embark on this learning journey together. To our Education Subcommittee Chairman, Optom Siabelo, who delivered the welcome remarks, we are grateful for your work, your warm and enthusiastic introduction. We are grateful for that. You highlighted the importance of this gathering and then set an encouraging tone for us that followed. We also want to say a big thank you to Optom Intula and our able President Optom Panika Naika for the introduction of our international speakers. We thank you very much for that. And we want to give a very special and a big thank you to our international speakers, Professor Dr. Bhandary and Professor Dr. Moodley. We are privileged to have you speak to us on the cases and the topics that you presented this evening. You have shared a very informative and educative lecture with us this evening. Your detailed presentations, thoughtful analysis, and willingness to share your expertise has sparked a meaningful discussion for us, and we believe that we will continue to take it forward. Your dedication to advancing clinical practice through this shared learning is highly, highly, highly appreciated. To all the participants who joined us from various corners of the globe, your presence and active engagement made this webinar a dynamic and an enriching experience. Your questions, comments, interactions has added immense value to our discussions, and we've all learned something from it this evening. Lastly, a big thank you to our administrative and technical team who behind the scenes have made sure there's been a seamless coordination. Everything has run smoothly, allowing us to focus on our content and discussions without any hitches. We thank you for that. So in conclusion, this has been a resounding success. We thank each and every one of us who made it a point to be here this evening, those presenting, those asking questions, those contributing, those who work behind the scenes to help make this program a success. We look forward to seeing you at our future events, and thank you and have a wonderful day ahead. Good night.
Good night, and thank you, Dr. Hakeem, for that. All participants, thank you very much for making our program successful, and have a good night. May all the gods that you believe in bless you. Good night.
Good night, all.
Good night.
I'm going to end the meeting now.
Thank you.